It has thought, and we are live. Hey, everybody, those of you who've joined during the live stream, great for you to be here. Please feel free to comment during the stream. If you're here watching the replay, still appreciate you being here. If you want to get any questions answered, just go ahead and send me an email or find me on LinkedIn and send a direct message and be happy to help you. Okay, so I'm going to count it back from 5, and then Jake's going to take it away. 5, 4, 3.
So, Kip, what are we going to talk about today in episode 217 of the Cyber Risk Management Podcast?
We are going to talk about life and death and what the technology stack has to do with that. In other words, what happens to patient care after systems that healthcare providers rely on, what happens when they go down? We've talked in the past, as you well know, about cyber attacks against medical centers and clinics, ransomware and that sort of thing.
Yeah. We had an
But
episode
this
called
is,
Killware, didn't we?
we did, yeah. But what we want to talk about here is the hours and the days after the attack, when the screens are dark and the staff are charting with pen and paper, which, that's just not the normal thing anymore. And those are care delivery compensating controls. They're the steps that the clinicians take to keep patients safe during this unplanned downtime. And what we're going to explore is that the stakes are not just at bedside. When care delivery degrades, so does revenue, so does the organization's ability to do the job that it exists to do. So this is a board level topic. It's not just a clinical one. This is a business issue. So we're going to have this conversation today with Mark Yaffe. Mark's here. He's so interesting during the episode prep because he's a practicing physician, but he also has a CISSP credential, which, in the legal field, that's also rare.
It
But
is.
I
think he's even more rare.
I do too. Exactly. Yeah. So he's got a really great, valuable perspective on this topic, right? A cybersecurity person like me, I can check that a hospital has a downtime policy and so on and so forth, but only a clinician can tell you whether that policy actually works at the bedside.
It's great, Kip. Mark, welcome to the podcast. Please tell us a bit about yourself and how, being both a doctor and a CISSP has led you to focus on clinical downtime.
Well, first, thank you, Jake, and thank you, Kip, for having me, and thank you to the audience as well for helping to make this show happen. So I'm a board certified internist, that's internal medicine specialist. Most of my practice has been based in hospital settings. And along the way, I started noticing how closely information security, cybersecurity relates to medicine. Medicine is practiced on the principles of confidentiality, integrity, and availability. And I've noticed the similarities with information security, where those concepts are extremely important. So that's how that was the motivation for me to get involved in cybersecurity as well. So this is how it got me here. Now, the natural place for me to be as a physician and cybersecurity person is downtime planning for downtime, because that's the natural bridge between cybersecurity and clinical care. It's where both skills are needed most. And the same thing goes for recovery time, because then we have to recover not just the system from an IT standpoint, but also clinical operations. So that's how I got involved with information security, and specifically in this area of healthcare information security.
Super interesting. And as Kip mentioned, this is, I think, at least our third episode that really touches on the intersection of cybersecurity and healthcare. But I think this is usually we talk about what happens up until the systems go down. And then we kind of are like, yes, bad stuff, things happen, clinicians do what they can. But we've never really explored what actually happens when the systems go down in a hospital. So from your
On the
perspective,
floor.
what actually changes on the floor, over the first few minutes, the first couple hours? Like give us some insight there.
Yeah, so there's few different things that could happen, and that depends on how much advanced information the clinical team has before this happens. So I look at it in two different ways. I look at it in terms of downtime that's planned versus unplanned. So again, these are a little bit of stylized versions because there's a lot that's in between. But planned downtime, the first thing we tend to notice is how quiet things get. So generally, medicine is very much a push system where alarms, bells ring, people come to us with information. So we basically react to the environment, the information that we get. That would be so now, once the systems go down, the first thing we often notice is the quiet. And we say, oh, how wonderful it is that we finally get a chance to enjoy the quiet and put our thoughts together. But this quiet is something that I often call pathological silence, where there's quiet there, but there are things going on. It would be analogous to a cybersecurity person going to work and their computer rings all day with different alerts, but now it's not ringing anymore. And one might think, oh, things must be going well, but not necessarily well. So that would be the planned downtime is similar to a lot of people who've been on a transatlantic flight or even an intercontinental flight, and the pilot says, "Okay, we're gonna nighttime now. We're gonna shut the lights here a little bit, dim the lights, make the cabin a little cooler, and then we're gonna have the let's say flight attendants go to the back of the airplane." So everything is planned, everything is calm, everything is collected. And the push system, which is the flight attendants coming to us and offering us drinks, offering us snacks, now becomes a pull system where we have to, if we want something to drink, we have to go up and go to the back and get that information. Medicine is similar that way during downtime because the information is not coming at us. We have to go look for the information. Where are these patients? How are they doing? Is everybody who's able to get in touch with us able to get in touch with us? Unplanned downtime is very different, especially when it's due to something that we don't understand. So if the electricity goes out, it's one thing. But if we have a ransomware situation or a cyber attack, then things don't make as much sense. And it could take quite a while to figure out what's going on, what's working and what's not working. So one of the clues would be if the system becomes hyperactive. In other words, there are screens that won't shut off, inability to log out, things behaving strangely. That would be a clue to that. And that would be analogous to being on an airplane that gets struck by lightning. And then the lights go crazy, bells ring, certain things go off, certain systems go down, and nobody really understands exactly what happened and what needs to be done about that. If somebody wants to see that in a movie format, you could see that in a movie called Plane, I believe it was in 2023. They have a scene of an airplane getting struck by lightning. A movie that most of us know would be Apollo 13, although it's involved with space, but still there are systems working, going crazy, doing the wrong things. So yeah, those would be the differences between planned downtime and unplanned downtime and the clinical environment that we often notice when these things happen.
Yeah, super insightful. Thank you for explaining that. And I think the analogy that you gave is super helpful because most people listening have been on an airplane. Maybe most people listening haven't really, spent time in a clinical situation.
The push. Sorry, Kev. The push versus pull difference is such an insight that I am determined to find other uses for it. But I will withhold further discussion so we can move forward with this. But I really think that's interesting, and it's. It's like you go back in time a century when the systems go down. It never occurred to me how much it would change the the way that medicine is practiced, right? And is there a concern, Mark? And I don't want to, this is so striking to me that I have to ask this question. Do you see a difference in generations of doctors as to how they handle the loss of electronic systems?
I would think if there is, yeah. So I don't think I would see a difference, but I do think it may feel different internally for different physicians. So everybody knows how to be professional and do the best they can with the situation. But I suspect
who's panicking more on the inside. Yes.
Yeah, exactly. Exactly.
Yeah, because they have to chart manually with a pen and a paper, and maybe I don't know. Do they even teach how to do that these days in medical school? I have no idea. But this brings up another dimension of this that I wanted to ask about. Just like Jake, I was like, I had this insight and I wanted to ask. So I would imagine that these days coverage on a floor is dictated in part by the amount of systems support that doctors and nurses get. So if the systems aren't there, are you not by definition understaffed?
Great question. I'll get to that in a second. The one thing I did want to mention is the first thing I wanted to mention is that anything that I'm talking about here is not setting up a standard of care and telling people how they ought to practice. It's a lot of the information is stylized in a way to help clarify certain points, but medicine could be quite messy in that regard. So I just wanted to make sure that I mentioned that.
Good disclaimer. I appreciate that as the lawyer on the call.
Yeah. So with regard to the understaffing, I feel like it's an amazing, excellent point. And the reason is it goes to the human aspects of it. And maybe we'll get to it a little bit later when we talk about system recovery. System recovery is not equal to clinical recovery. And it's certainly not the same as resumption of clinical operations or returning the clinical operations to the baseline, because you're dealing potentially with a backlog of work that potentially accumulated during the downtime. And yes, one could look at that as an understaffing situation, because anything that can't be done digitally could take more time to do mechanically. So yeah, a good way to look at it is an understaffing of sorts, I would say. Yes.
Yeah. Well, but isn't it true that if you flip from information being pushed at you to, hey, I got to go collect information, I need to go get vitals, wouldn't you?
That's what I was going to ask.
Wouldn't you? Yeah, you'd be understaffed for doing that too, wouldn't you?
For doing that, and it's just to build on Kip's question, because I can't keep myself quiet. And partly it's,
that's a new thing, everybody.
I know it's a new thing. Partly it's ignorance, right? But look, most of my knowledge of how hospitals operate comes from TV shows, right? I think that's probably true for the general public.
That's what I learned about the legal profession.
I know it's true. But I think just logically, if your systems are no longer beeping and buzzing and booping at you, don't you just need more nurses and medical assistants to walk around and be like, yes, this patient still has a blood pressure. This patient does not have a blood pressure. Like, how do you and if you're staffed in a way that assumes that push, that command center, central nursing station that we all see now versus the old way where you had nurses constantly roaming, isn't that just a major problem when the systems are down on an unplanned basis?
Yeah. So the major factors in how big the problem is or could be are the duration of the downtime and the expectancy of the downtime. And also the complexity of what's going on. So we'll take a more extreme scenario where the systems go down due to ransomware. Well, let's talk about the planned first, because I think it's easier to talk about the unplanned. So in a planned downtime, the first thing that would be recommended is to try to get as much of the work done prior to the downtime, put the orders in, check in on the patients, make sure that everybody's tucked in, so to speak. So when the downtime happens, there's less work that needs to be done during that time frame, plus the recovery and the reconciliation is easier. So that's the first aspect of it. Now, the next thing is sometimes you do need to recruit people. So it's not really an all hands on deck situation, but all necessary hands on deck. It would be great if some of the cybersecurity people could come there and say, hey, what problems are you having? There's a ransomware. Could you use this computer? Could you not use that computer? Sometimes leadership needs to show up. Sometimes the pharmacy needs to do a walkthrough, make sure everything's okay. So yes, I can't say who actually needs to be there and who doesn't, but certainly a lot of times we recruit additional help depending on what's going on. So those, I think, are the main issues or the main ways that we're talking about compensating controls. Those are some of the ways that we could compensate for the lack of data systems and uptime from that.
Yeah, it's interesting because we recently did an episode on the Seattle-Tacoma or the SeaTac airport ransomware attack that happened a couple of years ago. And our guest was Stephanie Warren. And that was one of the things she talked about too, is when the signage in the airport went dark and nobody knew how to get to, their gate or what their gate number even was. There were people who work at the airport in the back rooms, and they just got their orange vest on, grabbed a portable whiteboard, and headed to the air terminal to help passengers get where they needed to go, even though that really wasn't their normal job. That sounds like what you're talking about.
Absolutely, yes.
So
go ahead.
The next question I think is, and I think the airport example kind of makes it clear, is that it doesn't seem like this is gonna look the same everywhere. And what I mean by that is, if you've got unplanned downtime in an emergency room versus a regular hospital floor versus an outpatient clinic, do you think each setting needs its own unique plan, or is there a generic, clinical compensating control catalog that just works for everybody? And I think the answer is clear, but
yeah. I think there's a little bit of both. The general concepts are the same. So, for example, planning, if it's planned, not touching anything. If it's unplanned, the push versus pull aspect of it, those are generalized. But these things I don't think could be planned exclusively on the executive or leadership level, because there are some variations depending on the location, inpatient versus outpatient, and depending on the practice as well. One example I could give is the behavioral health, the psychiatric ward. Psychiatric ward is very, very different from the medical ward. Reason is the windows and the doors are part of the health care plan. Certain people are not supposed to leave the vicinity. And what happens if systems go down? Do we have a fail open position where patients are just able to walk out onto the street?
That's such a good point, because in a hospital, you can't just be like, oh, fail closed, because then doctors and nurses can't get around to where they need to go. But if you have fail open,
yes,
that's interesting, fascinating. It never would have occurred to me.
Yeah,
One
another
flew over
point.
the cuckoo's nest.
Yeah, no, literally, yes.
Another point related to that is that system downtime is not the same as clinical downtime. Number one, because clinical care needs to continue. But number two is the clinical aspect could actually result in a hyper uptime state, so to speak, because there are things that come into play that are not a decrease in clinical activity, but an increase in clinical activity. One example would be a fail open door. Another example would be interventions that the physician has started because they didn't have the ability to do the testing that they need. And what happens after the system comes back up, the clinical aspect of things need to be downgraded. So, for example, somebody who's in the intensive care unit and deserves to go to the floor, they're not transferred because of the complexity and because the system is down. Now they have a hyper uptime state from a clinical standpoint because they don't need to be in the intensive care unit. So we have to go back and reduce the care to the baseline for that patient.
It's very complicated. I'm feeling very overwhelmed by this. I mean,
I could take another stab at it if you.
No.
We understand it. It's
we
so
understand
overwhelming.
it. It's I feel like the world
There's a
needs
lot.
about 700,000 more Mark Yoffes, because
Whoa.
the combination of MD and CISSP is so unusual, but I think you're proving why it's unusual. Like this idea that clinical uptime versus system uptime and system downtime, like I don't know that anyone else notices that difference, frankly.
Well, when
Right, Kip?
everything's running correctly, you don't,
Yeah. Well, I
right?
think
'Cause
the perspective, right, is most people are either a doctor or a cybersecurity professional. I just don't know how many people are both. And
right.
the insight, the changes that you get. I mean, like our merely a suggestion script, talks about how um, it's an outpatient clinic can usually reschedule a visit. Like that's another very different example. The hospital floor in an emergency room, you don't get to be like, I'm sorry that you've broken your arm or have been shot, can you just come back in an hour or 3? Like you can't do that. Like that's not
Right.
an option. And
Right.
that
Although
really does.
you can divert them to another facility,
You
but
can
that's
divert them to
delaying
another
care.
facility, but that also has to be coordinated, right? Because if
Oh,
you think
yeah.
about a city, if you think about a broader city, set of medical care and clinician capacity, you can't just be like, oh well, that's fine, we're just going to send all our patients to you. I mean, you have unlimited capacity, don't you? No, they don't
Right.
have unlimited
That's
capacity.
right.
Like this does not. This Yeah, that's all
There's
I
a
have to
lot
say
going
about
on
that.
here.
It's a lot
Yeah.
going on here, and the
Well,
stakes, and the other thing too, Kip, is like I feel like you and I a lot of the time when we talk about ransomware attacks and system downtime, like it's mostly money, right? At the end of
right.
the day, it's cash, right?
Yeah.
If a factory can't make its widgets, rarely is it life and death. That's what makes this. That's what makes these episodes. I feel like we need to have some kind of like content warning, because it's just so much more frightening and visceral
A bit
than
more dark.
that. A bit. Well, I mean, it's just reality.
It is reality. Now, just so everybody knows, we have, Jake, you mentioned at the top of the show, we've done a couple of episodes in the past, and I'm going to put this in the show notes, but in episode 97 is when we talked about killware, and episode 151 is where we asked the question, does ransomware kill sick people? And, I'm sorry to bust anybody's bubble, but, the answer is yes. Unfortunately, it does. And, that's why this conversation continues to be important. I'd like to talk about ownership. So, Mark, your first point was that care delivery compensating controls need a named owner. But why isn't this just the technology team's job? I mean, why not give it to them?
I think you've mentioned that at the beginning of the show, and that is that to know whether a control is effective clinically, you need to have somebody who has a clinical understanding. Does it have to be a medical doctor? Maybe not necessarily. There are nurse practitioners, there are physician's assistants. So somebody who's very familiar with how medicine actually happens. And there's a transition there, because IT could tell you systems are up, systems are down, and they could also tell you what the general implications might be, and that is a lot of it is common sense. So let's say if the pharmacy systems are down, it's certainly going to be harder to get the medication out. That's reasonable.
Yeah. How true is it? How true is it what you see on shows where like the drugs are kept in this thing that only opens if a certain command is given, and like is that true? Like you can't get them out.
Yeah.
Is that real?
Yeah, so there are medications that are held in the pharmacy, and there are medications that are held on the floors. And usually the medications that nurses need quick access to are on the floors, and many of them, especially when they're restricted medications like narcotics or sedatives, those are under a code that has to be punched in, and sometimes it actually requires a signature of 2 or password of 2 to get into that. So yeah, that is seen often.
I mean, imagine being a patient in extreme agony, needing morphine or whatever the modern version of it is, and oh, I'm sorry, you can't have it because there was a ransomware attack and
Oh
the
yeah.
system won't let us log in to unlock the morphine. I mean, I, I yeah, that is a crazy, but I'm sure it has happened and it's scary.
Yes. And that brings me to the point that it's up or down is not a binary thing. When things go down, sometimes it's only one system goes down or several systems go down. Um, it's not always binary. So it's important to know and communicate what's down and what's not. So, for example, sometimes the phones are actually not going down, but people might hesitate to call because they're assuming that everything is down, so everything is down. So it's important, I believe, for the IT team, especially if it's unplanned downtime, to communicate as best as they can. Number one, what's down. Number two, what not to touch. And number three, what's clean and could be used. And that's very, very helpful at the bedside as well.
Wow. So what else can you tell us about the clinical compensating controls? It's not the IT team's job, but like, you know, whose
Needs to
job
be a
should it be?
clinician.
Yeah, like, so you have a clinician, you have someone with clinical experience, but like, how many people? How is it done? Like, should it be formalized? Should there be committees? Like,
And
what
how
are
do
the
you
gaps
scale
that
it?
you see? Yeah, how do you scale it?
Yeah, well, the ultimate responsibility, I would say, is with the healthcare executive, with the leadership, because they're in charge of the governance. But certainly they assign ownership to IT, to department leaders, because the department leaders are probably in the best position to know whether the compensating controls that are being proposed actually would work in clinical practice. Now, who needs to be the overall owner depends very much on the size of the institution and the philosophy to some extent and the approach.
Hmm.
In a lot of places, they'll have a committee between IT and the clinical side. But then you have a situation where if there's a shutdown decision, IT is the ultimate owner of the decision with input from clinical. Well, should it be the other way around? That's a little hard to say. Um, uh, you could also have somebody who has clinical and cybersecurity abilities who doesn't have a formal position, or you could have a formal a position for someone who straddles both cybersecurity and clinical care to oversee and to own the entire downtime preparation process, the downtime controls that are actually implemented, and the recovery process from a clinical standpoint.
Yeah. Now, one thing that I think I want to just kind of highlight here, because I think it shows one of the differences between, the the medical clinical situation and a lot of the clients that Kip and I have worked with is, we obviously always tell everyone you have to have an incident response plan, and you need to plan ahead, right? That's why we do tabletops. That's why we do all these different things. But it seems to me that, a lot of I'll just call it lower stakes, which I think describes most businesses that are not truly life and death. I think a lot of them feel like, despite advice to the contrary, that an incident response plan and practicing it is a nice to have. But in the clinical healthcare setting, I'm realizing, just based off the 28 minutes that we've been talking so far, the complexities here are so immense that it really feels like, a hospital that hasn't put significant resources into the plan, kind of negligent. What do you think
That's a
about
big
that?
word you don't throw around
It,
easily.
well, I mean, it is. But that's because, I mean, look, if downtime can be anything from a bad storm knocking the power out, and then you can say, oh, well, why didn't your generator go on, and blah, blah, blah. But like, we all know these things happen. So it's not the case at this point that anyone could be like, oh, we didn't think about that. I think it is. I think it would be. I think it would be almost grossly negligent, frankly, if I'm going to throw big words around. So, Mark, I'm curious, what are your thoughts on that?
Yeah, so this harks back to the disclaimer, obviously, that I
Yeah.
said earlier.
Yeah.
But I think it's very, very important um, to have care continuity planning ahead of time, to have that in place, to have that plan, to have the appropriate validation done to make sure that it works, because the natural response is, well, why did you get hit with ransomware? Is, well, the bad guys did it, and you could actually garner a lot of sympathy by saying that, because the bad people are not here. They monetized it and they ran off with the money.
And
Everybody
they are bad guys. I mean, they are criminals.
Yep.
right.
Yep.
And
we
they're
didn't
not
ask
here
the
to
attack.
answer to it. And we're really sorry that this happened. And I think people are very sympathetic to that point of view. However, when the
But
questions start,
only to a point.
okay, sure. But I'm contrasting that with the questions that start happening. Well, how well was this prepared for?
Yes.
What was actually done when this happened? What the recovery process looked like? Then, the bad guy, so to speak, that started it all, they're not in the picture anymore. That's the
No.
question that yeah.
It is, and it's so fascinating because, we could have this discussion in the year 2000, in the year 2010, and then now, right? And the answers are different, right? And from a lawyer's perspective, when the answer changes, that looks to me like the standard of care evolves as the facts of the world evolve. That's a negligence or malpractice type of issue. I think it is not it is not overstated to say that cybersecurity downtime planning, not just incident response, but disaster recovery and business continuity, use whatever three-letter acronym you want to describe the appropriate plan. It is a component of the standard of care of medicine. And I think you don't have to say this, Mark. I will say it. I think it is medical malpractice to operate a healthcare facility without having adequately planned for unplanned downtime. I think it is. And I think if that has not been tested in court, and I don't know that it hasn't, but I also don't know that it has, it will be. I'm 100% sure of it.
Yeah, one thing I will say is that when we talk about care delivery continuity planning, that is a portion of business continuity planning. People might be uncomfortable saying business when it comes to patient care, but the business of a healthcare organization is delivering care. The mission of a healthcare organization is delivering care. So it's an aspect of business continuity planning.
Yeah.
There's other things that are needed to continue in business, which is billing and so forth, but a component of business continuity planning for a healthcare organization.
Well, and you know what? You can rename it the mission continuity planning, right? Business, I think, does have a bit of a connotation there, and to me, that word in that situation really just means the thing, the thing that the organization does, right? Mm-hmm. But I think but I think you're right. I think there's a psychological component to it, and I would be perfectly fine with, if people called them, mission continuity planning. Particularly if you're a nonprofit, you're like, well, we don't do business. Okay, fine.
Yeah.
It's a mission continuity plan. Confusingly also known as MCP, which we can't use because of model context protocol. That's an AI thing. But no, this is super fascinating. So
TLA collision.
TLA collision. Yes. Let's talk about workability for a minute, because I'm certainly convinced. I think, and Mark, you've started convinced. Kip, hopefully we have convinced you that this is all very scary and very important. But so let's talk about workability, right? This is a big deal. I think Kip and I spend way more time on this word than we realize. I'm not sure we've used it before, but the idea here is that a policy can read well, but still fail in real life. So what makes it in this context, Mark, what makes a downtime control actually workable? And Kip, side note, we should probably start using that phrase outside of the medical context.
Okay.
Yeah, so firstly, I would say that there are national guidelines that are coalescing around these issues, and there are actual recommendations. that are coming together from different organizations, and there's work being done on that to actually come out with more unified guidelines as it relates to that. I will say, though, that this is mostly anecdotal, because you can't really do studies safely on, okay, well, let's shut down the computers for a day and a half and see if this works. So have a control group.
That's not going to
So
work.
It's really expert opinion, and maybe anecdotal is not the right way, but case series certainly, well, having done and having seen it multiple times, what works and what doesn't, but you can't really design
case studies. Case studies is
the
acceptable version of, really, it's just anecdotal.
Many anecdotes don't make data, is what I've heard before. But certainly, yes. Well, it's better to call it case studies or case series. So how it works is experience actually working in those environments and actually seeing and learning, kind of like a residency where you learn medicine from the books, but when you go out in real practice, it could be different. Same thing with cybersecurity, by the way. There are people who maybe have credentials or education, but actually doing it is quite different. So
I think we can agree that is the case.
Yes. So having experienced people working that area and gaining experience and teaching about it, I feel like is very important. And also various root cause analysis, for example, is an important part of it. So let's say there was a bad outcome on the floor. Patient didn't make it through the night at 2 a.m. Systems happened to be down, and we want to know, was this related to the downtime or not? So we could do a root cause analysis to try to help determine whether the two are related. And granted, root cause analysis is associated with hindsight bias and all sorts of things, but that's another way. And the other thing is to prepare with tabletop exercises, make that part of the disaster recovery plan, the business continuity plan, meaning every time we do a business continuity plan, we don't just isolate, let's say, the accounting or the billing department, that we try to do it as part of a comprehensive plan and see how it actually plays out or would play out in real life situations.
Geez, there's so much going on here.
There's so much going on. So one of the ideas here is that, a policy that looks good on paper and still fails when it assumes that staff can, I love this phrase, safely improvise with degraded information. Now, as a lawyer, I don't, that is the phrase staff can safely improvise is a little worrisome. If a control quietly assumes people will just fill the gap on the fly, what is the risk that we're really taking on there? Like, what is that? Like, that seems to be, I'm sure it happens.
Seems
and
big.
if you watch too much TV, you would assume that the entire practice of medicine is actually improvisation, because you can't possibly know what's going to happen every minute to minute, and it's everyone just running everywhere because action is good on TV. I assume that's not truly accurate, but nonetheless, I'm sure improvisation happens quite a lot.
Yeah, Jake. So I mean, that question actually verges on the philosophical almost, and it gets me to think that the entire concept of licensure is really a mitigating control or a compensating control for the things that we cannot ahead of time regulate. So take, for example, a pilot. If we were able to account with a computer for every contingency, then pilots would not be licensed. In fact,
you wouldn't need them.
You wouldn't need them. So the presence of a license, a professional license, implies the need for a compensating or mitigating control, and that applies, by the way, to every profession, law.
Oh, absolutely.
Okay. So when we issue a license, it's in a sense an admission that there's going to be, if not improvisation, but certainly new scenarios,
judgment calls
that we haven't seen before. Number one. Number two is we need to recognize that once a playbook gets jammed with every contingency, you start losing the forest for the trees kind of thing. So it has to be a judgment call as to which contingencies belong in the playbook and which don't belong in the playbook. The third thing is that we can have really controls over the improvisations. And the example, again, goes back to the Apollo 13, where they had this device called a carbon dioxide scrubber that removes the carbon dioxide. That didn't work. So they had to build some kind of system rigged with duct tape or whatever it was to make it work. Now, what was the control, the compensating control that they had is that the people on the ground, they had all the equipment that they had up in space. So they were able to build a prototype on a desk and say, we were able to put this together with a prototype that basically represented everything we had. So go ahead and do that in space. We know it's going to work. Point is that even though we're improvising, we could improvise in a way where control over the improvisation takes place. So an example would be if, let's say, the AI system is down, and I need help with a diagnosis. What do I do?
That's why you went to law school. I mean med school, but yes.
Yeah. So that's exactly the idea. So is there a colleague there who can help? Are there certain procedures that I should really defer and wait till later? So for example, if a patient needs transferred to what's called a tertiary center or a different facility, systems are down. Do I send the patient without any records and just a phone call? Well, yeah, maybe if it's a very, very life-threatening thing, that's necessary. But otherwise, it might be a clinical judgment. Hey, let's just wait 3 hours, see what happens. Maybe when the system comes up, we'll be able to print out the discharge summary and send the patient. Yeah. So I would say, in conclusion, is the mere fact that you have improvisation or you're working with less information doesn't automatically mean to me that what's going on here is improper. In fact, there are ways to mitigate even for that and to work with that as a licensed person.
We are running out of time.
Thank you, Jake. Thank you for being the timekeeper.
I know I was going to be the timekeeper, but I do want to hit one last thing: this idea of the memory hole, because I think it is actually one of the most stark examples of why recovery is part of any good incident response plan, and why, as cybersecurity professionals, the original NIST cybersecurity framework had only 5 functions. Recovery was one of them. Now there are 6. Recovery is still one of them. This is the memory hole issue. Mark, just explain that to us. Give it to us in the quick, because we are running out of time. Okay. But I think it's such a good example of the problem of system downtime and thinking through all the implications of it.
Yeah. So the memory hole is basically information that didn't make it back into the system on time for it to be clinically actionable in time. So that's what I mean when I say a memory hole. So it's something that either didn't make it or is at risk of not making it. The memory hole has actually several compartments, but since we're short on time, I don't think I'll get into too much detail. But one example would be, let's say, information that was done. A nurse took vital signs and wrote down the results, but at the end of the day, it ended up in what might be called a shadow chart. It never made it back into the system. So that's one example. And
I assume giving someone a medication is one where the consequences of having no record of that would be way worse than, they took, I didn't get your blood pressure for one time, is way different than, did we or did we not give him or her that medicine?
Right. We don't want an overdose.
Another part of the memory hole could be a care delivery memory hole, but that's not quite a memory hole. That's care that wasn't done. Vital signs that were skipped, for example, and now we have information missing. So that's not necessarily a memory hole, but that's a gap in information. Another type of memory hole is a care connection memory hole, but that's a whole different topic, and that's the idea of who's not here, who's supposed to be here. When we're dealing with patients, we'll say, well, whoever's here needs to be here. The ambulances are working, telehealth is working. The doors are being locked in the behavioral unit. So whoever's here needs to be here. Whoever's not here doesn't need to be here. But once you have a system downtime, well, who didn't make it to their doctor's appointment on telehealth because the system was down? Who eloped and walked out of the unit because it failed open? And the fourth memory hole is actually a technical one. If the system goes down and we have to use a backup, the backup might not be recent enough. So it's the last clean backup or last known normal backup, but clinically that might not be the best backup we could have. And could be a gap in information from, let's say, if we're storing information from 1 day ago, and now there's a gap of there's a memory hole of that 24-hour period.
I mean, so that's another it's another example, Kip, where it's just like the stakes are so different, right? If I tell my business clients, well, the best I can do is get you a day ago, most of them are going to be like, awesome, restore that backup. If I'd say that to a hospital,
right,
that's a totally different experience.
It is. Okay, so we are running out of time, but before we wrap up, I do also want to acknowledge that senior decision makers in a hospital setting, they play a big role in this, and I wish we could unpack it more fully, but I'll just simply say that a signed policy saying y'all are going to do this isn't enough. There's more to it that we need from senior leadership, and guess what? That's not different fundamentally, conceptually, from other situations where the tone at the top has to be set and people have to know that these things are real expectations and that there's consequences if those expectations aren't met. Anyway, thank you, Mark, for being here. Really appreciate it. Wonderful information that you've shared, and I feel like we should probably have you back again.
Yeah, I was thinking there's at least another episode or 3 on this topic. It really does. I mean, I thought that I knew the consequences and the complications of this, of cybersecurity risks at hospostals, but I'm realizing now that I only thought I did. I think it takes someone. There's a lot more nuance. And again, that's because, I can look at the law and the cybersecurity stuff, but I don't know what I don't know about the practice of medicine. And apparently watching Grey's Anatomy is insufficient training.
I don't want you to be my doctor. You can be my lawyer.
You really don't. You really don't. I'll just yell things like clear and stat and jam needles and see what happens.
Just don't be House, okay?
Yeah.
Nobody needs that. Well, this wraps up our episode of the Cyber Risk Management Podcast. Today we talked about care delivering compensating controls for healthcare downtime, how care reverts to the analog world when the digital systems go down, who needs to own the care delivery workflow, how do you make controls workable, and a lot of nuance and the memory holes, all kinds of really interesting aspects of this. And we did that with our guest, Mark Yoffie, who is a medical doctor as well as the holder of a CISSP certification. So it's really great pleasure to have you here. And we'll see you next time, everybody.
See you next time.
See you. Thank you.